ask about another issue that I know has arisen in our group in discussions. Abnormal pain processing, like exercise-induced hypoalgesia and pain sensitization, how do they affect recommendations related to strength training? I don't know if any of you have sort of begun to address this concern. Are there some people who have different responses to exercise with respect to algesia responses?
I want to say there are studies that we really are considering when we talk about this in journal clubs in our clinic, which is a very research-based clinic. But it always, when we come back to these discussions with the clinicians and the residents, the PT residents, what always seems to come up is, what do we do about it? How does one address this? And I'm at a loss.
Let me just follow up from Jackie Whitaker, which, and I'm happy to unmute her if I can find her, is that by downtraining, she was really referring to problems with co-contraction and whether you want to try to do anything to eliminate or minimize co-contraction. Is that part of the initial evaluation that some of you talked about? Is there a need to understand whether there's a lot of potentially dangerous co-contraction going on that might need to be modified or down trained, as it were?
Well, David, some co-contraction is good, right? Because it helps to stabilize the knee, all right? So you don't want to eliminate co-contraction totally, but if you have too much, then of course the muscles are where most of the force on the load on the knee is coming from, right?
Right.
In addition to just the body weight. So you want to try to minimize that. We found that when people lose a lot of weight, co-contraction goes down. Quadricep force goes up, hamstring force goes down, just with the decrease in the load. So I think with training by itself, I think that kind of, as they get more used to doing the exercise, or if there's some weight loss with it, that I think that kind of takes care of itself. I don't think we have to interfere with the process that takes place as people get more fit.
I think that in our PTOA population, when we see co-contraction early, we think it's a bad thing. And we have developed strategies like perturbation training for trying to break up that co-contraction. So I think it's different in those.
Yeah, and to follow up on that, I agree with Neil. I wouldn't call it detraining. I would call it that we address the co-contraction. You can measure this, or you can just at least qualitatively evaluate it in the clinic while you see patients hopping during the landing phase. You see this stiffening of the knee, and these are also things you address in the clinic. But I wouldn't call it detraining. I would use perturbation training, as Lynn said, because we know that helps.
Okay. I think the one thing I would just add, and Steve, you kind of alluded to it, was it depends on what your thoughts are regarding the increased compression that you would get from a co-contraction versus the increased stability. And I would argue that for someone who's got a relatively stable joint, I think co-contraction is bad. For someone who's got a very unstable joint, I think as you said, some level of co-contraction is probably a good thing to maintain that. And so to say co-contraction is good or bad across the spectrum is probably not appropriate.
I unmuted, I think, Tuhina Nioji, who can speak a little bit to pain processing and exercise-induced hypoalgesia. Tuhina, are you on?
Yes, thank you. I really think that's a very pertinent question, since exercise and strength training is first line, but if someone has abnormal response and they don't get, or they have impaired exercise-induced hypoalgesia, it would be ideal to address it. And Lynn, to your point, the question is, well, what do we do about it? And so I do think that's an important clinical question about strategy, because obviously if someone has impaired exercise-induced hypoalgesia, sending them off for strength training and exercise first may set them up for failure. And so I think an active area of research needs to be in phenotyping these individuals and then figuring out what to do. We have some studies in the field where we're assessing this. And I think it speaks to the broader issue of needing to better understand these altered nociceptive signaling pathways and functioning, and how to address them. Another issue that we've noted is that pain sensitization is associated with more muscle co-contraction. So this isn't only, pain sensitization isn't only about the pain experience, but may have effector implications as well. And so, Lynn, I think the clinical implication for what to do about these individuals is something that we're studying right now about how to alter that response to improve it so that they can have the expected exercise-induced hypoalgesia.